Hello, everyone. My name is Mary Ellen Stanton, known to some of you as Munch, and I'm delighted to be here today and to welcome you to this session. I'm a midwife, and I've been at USAID as an advisor in maternal health for many years, and I've been working on the issue of respectful maternity care since 2010. I'm very pleased to be asked to moderate this panel as an opportunity for me to learn more about maternal mental health and think through the association of mental health and respectful maternity care with both the provision of maternity care and health outcomes. On the positive side, it seems logical that respectful maternity care and maternal mental health should reinforce each other and therefore promote emotional wellness and help women to take on or expand a positive parenting and nurturing role. On the negative side, it's also plausible that mistreatment of women in pregnancy and birth and afterwards would result in trauma and therefore be detrimental to a woman's mental well-being. Furthermore, if a woman enters pregnancy and birth in a serious mental distress and then experiences neglect, abuse, or humiliation, mental health problems could be exacerbated and negatively influence her postpartum course and the ability to positively nurture the child. We, of course, do not have all the answers to this, but our panelists will help us reflect on the convergence of RMC, respectful maternity care, and maternal mental health. One of the things we've learned in RMC is that it's too simplistic to think of victims and perpetrators. Many healthcare providers lack role models, skills, and motivation to provide nurturing care to women during labor and birth, and many, often unintentionally, inflict disrespect and abuse. If that is the case, are they in a position to recognize and mitigate mental distress in the turmoil of patient care? What can be done in the community to identify and assist women with mental problems even before the onset of labor? Finally, is there anything we can learn from global respectful maternity care movement and from national efforts that will help guide our work in maternal mental health with respect to advocacy, research, measurement, and programming? So we've got a lot to dive into. This is a glimpse of the topics our panelists will take up today, and we hope to have time to have some of your questions and observations. First, I'll introduce the panel. Patience Fulani is a Ghanaian-trained doctor, now an assistant professor at the University of California, San Francisco. She carries out outstanding research on social and health system factors underlying MCH disparities and has a special interest in RMC. Adaya Metash is a consultant at the Department of Sexual and Reproductive Health and Research at WHO and a PhD student in implementation science at the University of Washington School of Public Health. At WHO, she works on research portfolio related to quality of care and women's experiences during childbirth and safe abortion. Charity Nwika is a program officer at Pop Council's Kenya office, working with others on the Heshima project. She developed and tested interventions to promote dignified maternity care during facility-based childbirth. Is currently working on research that seeks to promote positive inpatient experience for sick young children and their parents. Finally, last but not least, Dr. Mary Sando is a Tanzanian medical doctor and public health specialist who has been greatly involved in efforts for advancing respectful maternity care in Tanzania. He's currently leading efforts in the Africa Academy for Public Health in Dar es Salaam to advance implementation, science research, and support capacity building for research, evidence translation into policy and practice. So we're going to start off, and I'll pose the first question to Patience. Patience, would you describe any linkages in health outcomes between respectful maternity care and mental health?
Thank you, Manch, and it's an honor to be on this panel. So I think we still have a lot to learn in terms of linkages between in health outcomes between RMC and mental health, given both have only recently risen to prominence in the global MMH discourse, and they continue to be evolving areas of research. But there are a number of linkages we can make based on the existing research. The first is the relationship between women's birth experiences and their mental health postpartum, which you alluded to in your introduction. So there is research showing that women's birth experiences, or women who have traumatic birth experiences, are more likely to have post-traumatic stress syndrome from following birth. And this includes traumatic experiences from mistreatment and other poor patient-provider interactions. Other research, including actually our work in Kenya, also points to the fact that women who receive poor person-centered care during childbirth are more likely to have depressive symptoms in the postpartum period. There is likely some reverse causation going on, which is that women with poor mental health may be more likely to have poor birth experiences. So for example, women with certain mental health conditions may experience stigma and discrimination during the prenatal, intrapartum, and postnatal care, leading to an overall poor experience. But regardless of which direction, it highlights that we have this relationship between women's experiences during childbirth and mental health outcomes, and we need to be addressing both. A second potential linkage is through health-seeking behavior. So we do know that mistreatment, whether personally or vicariously experienced, deters women from seeking health care in a timely manner. And if women do not seek care in a timely manner, especially in the postpartum period, mental health issues such as postpartum depression will not be identified early. Further, our ability to adequately diagnose and manage maternal mental health requires that we are providing care that is responsive and that is respectful to the needs of the patients we are serving. And so RMC can influence both detection and management of maternal mental health through direct and indirect pathways. On the other hand, poor mental health in the prenatal period could affect timeliness of antenatal delivery, which we know could lead to further disrespect and abuse, given providers take it out on women who start their antenatal care or present late in labor. And the third linkage I'd like to mention is related to providing provider mental well-being, again, that you alluded to. And we can come back to this point. But we know that one of the drivers of disrespect and abuse among providers is provider burnout, which has implications for provider mental health. And so providers' mental health can have direct effects on the provision of respectful maternal care. And finally, I just want to tie this back to your mention of women's emotional well-being. When women are treated in a way that is responsive to their needs, their preferences, and values, when providers are compassionate and respectful and supportive, and women feel engaged in their care, they feel satisfied, they feel valued, they feel empowered, which promotes positive emotional health. We still need research to confirm some of these linkages, but I think we have enough evidence to say that there is likely a cyclical relationship between RMC and maternal mental health. Thanks.
Thank you so much, Patience. Hadiya, I wonder if you have something to add to this around what women want.
Sure, and I think that the the linkages between that is some of the systematic and qualitative scoping reviews that WHO has undertaken across the continuum of maternity care, from antenatal care, intrapartum care, and postnatal care, looking at what matters to women to try to really understand what psychosocial aspects might be important and what women want and expect from these services. And based on the systematic reviews conducted on 2016 on ANC, the study found 4 themes in terms of maintaining physical and social cultural normality, and also achieving positive motherhood, including maternal self-esteem, competence, and autonomy, which links back to some of the discussions we're having today. In terms of intrapartum care, also the review found that most healthy childbearing women wanted a positive birth experience, including psychosocial well-being, being equally valued. And so to really to have care being designed to really fulfill women's personal and social cultural expectations and values. In addition, there's most recent What Matters to Women review on the postnatal period found that in order to ensure postnatal services can better meet the needs of women and their babies, what mattered to women was really to adapt their new self-identity and develop a sense of confidence and competence as a mother, adjust to changes in their intimate and family relationships, including their baby, and navigating ordinary physical and emotional challenges and the new experience and the dynamic of achievement of personal growth as they adjust to the new normal of motherhood and parenting. And I think that this really highlights the importance of the linkages between these two areas and the connections. And furthermore, in terms of the advocacy and advocacy movements, there's the Respect for Maternity Charter that has been recently published in 2019, but also the What Women Want movement of the top 20 demands to respectful care was one of the top 20 demands that women were surveyed and were found to want. So I think this is an important topic that we need to continue to focus on and link.
Thank you so much for that. There's so much to unpack on that. I do want to, though, go on to another question and ask of Charity. What you can tell us about how negative experiences of care or disrespect have been associated with provider behavior, norms, values, and the work environment stressors that we see so often. Charity? We need your microphone, Charity.
Thank you, Matt. Provider behavior is a result of both personal and environmental working factors, and this too has been found to lead to provider burnout, among other negative outcomes. When we think about burnout is influenced by 3 interlinked constructs. The first one is economic barriers. Providers either receive low salaries, their salaries are irregular, and they have at times they don't even have time to take leave. Therefore, they can't even make any other income to supplement their pay, their low pay. And the other factor is professional barriers. This includes lack of equipment and supplies for offering maternal health services. Providers also lack recognition. They're also not present in policy-making dialogue and decision-making. That is decisions that are being made about their work, their pay, and so on. And these causes it can lead to burnout. The other factor is social barriers, that is gender inequity. We all know that many providers, especially the first-line providers, are women, at times working in fragile environments, and at times also not very valued by the community that they work in just because of their female gender. There is also disrespect of health workers, either by others in some other cadres, and also lack of teamwork or peer pressure in terms of, even if when you're doing so much, what are you working for? What do you have to show? So that then this brings burnout. Given that, burnout can lead to poor communication. And when this happens, providers can be rude. They can be angry and use high tone when talking to the mothers or postnatally or during labor and delivery. They can also choose to be silent because they feel like they are very tired. There is also inability to listen. They can't listen or pay attention to the mother's needs or wants, whatever issues the mothers may be raising. There's also poor teamwork among providers because of burnout and poor communication. Then due to the above, patients will face neglect, they'll be abandoned, they'll have fear to express themselves, and hence the patients will not have rights in decision-making, in the services that they are receiving, or they also not demand for respective care, even when they know so, because they are cowed, they cannot express themselves. In this scenario, we see that both the provider and the mother are experiencing psychological stress, and thus the intervention should target both the providers and the parents or mothers in labor or during the postpartum period.
Thank you so much, Charity. That really actually gives us quite a picture of the environment and the stressors on the provider who are needed to identify and address women's mental health issues in a very busy and stressful environment. I wanted to now turn to Hadia and ask what you think that the maternal health movement can learn about measurement from the RMC movement. Where are there convergence and where might there not be?
Sure. So I can speak to the RMC movement and how the different terminology has developed over the years. Starting with disrespect and abuse with the really key background report that came out in 2010, and then shifted to other regions, mainly obstetric violence, which was mainly used in Latin America. And then the systematic review the WHO conducted in 2015 around mistreatment of women, which really places the woman at the center with woman-centered measurement approaches. And then the evolution of that to respectful maternity care, which includes, is a broader concept than merely preventing the mistreatment of women at childbirth, but is a broader concept and really is in accordance with a human rights-based approach to reducing maternal morbidity and mortality and improving women's experiences and addressing health inequalities. And also our RMC as a broader term can be supported and promoted at all three levels of care: individual, health facility, and health system. So really it encompasses a broader concept, and I think this is where we're moving towards in order to be more inclusive in terms of the terminology and how this also connects back to some of the areas. And then in terms of measurement, there was a recent scoping review on measuring experiences of care during maternal and newborn care with over 170 articles across 56 countries that found of these articles, half are not using a validated instrument. Most of the articles are currently on intrapartum care, and only one on early pregnancy and abortion, and there's very few on antenatal care and also postnatal care. The most commonly reported domains, which from this review that found where users' experiences were communication and respect and dignity. So it really, with all of the evidence that's currently available, these are some of the highlights of the systematic review, looking at some of these measurement areas. Furthermore, the primary purpose of most of these papers was largely through cross-sectional surveys. So while many instruments exist for user experiences during the maternity period, these instruments still need to be consolidated, validated, and expanded based on the purpose of the research and accountability mechanisms. And I think the next step really moving forward is understanding the current state of women's experiences is to use similar instruments across multiple populations by beginning with one or more validated instruments that are currently available and adapting it to countries and populations, and also then adding it to one of the larger scale surveys, including the service provision assessment and demographic and health surveys and other multi-country surveys, which would enable harmonization across the tools in order to reduce and reduce measurement burden, but also improve RMC globally. And so future research should apply these measurements specifically also to underrepresented and underserved populations like adolescents and other vulnerable women across the continuum of care, which we've found that there's been very few areas. And lastly, to say that positive experience is really not a luxury, but a necessity at this point, and therefore efforts to improve this really should be including to harmonize these measurement areas, and also in order to improve quality of care, they should really be able to focus and improve this via measurement. Thanks so much.
Thank you so much. I think WHO work that Patience is doing and so forth are really moving ahead this area that we've been waiting for on validation of metrics. And so I think we're moving into a new age on that, I hope. Patience, I think you have something to add to this discussion.
Yeah, the one additional thing I wanted to add was thinking about where measurement for RMC started. So initial research on RMC was mostly qualitative, which is really important. I mean, the issue was not dismissed because we could not quantify it in a uniform way. Having several qualitative studies provided these rich and in-depth descriptions of the problem from the perspectives of women in different contexts. And it was these initial qualitative studies that informed the categories, the domains, the typologies that I had mentioned in subsequent literature reviews, leading to the development of quantitative measures. And again, although initial quantitative measures were not standardized, are still not standardized, they give us enough indication of the magnitude of the problem to drive change. And so we are not waiting until we have everything perfect in terms of measurements before we begin to think about what is driving disrespect and abuse, or what is leading to women not receiving respect for maternity care, and how can we improve it. I also think it's important for, and we're developing validated measures. I think the important thing is that even though we are developing these validated measures and we're thinking of standardizing them, the context remains very important. And so we are not just thinking of a measure that will capture everybody's experience perfectly, but that there are measures that will capture, for the most part, the things that are of value to women. And these are things that we have learned from the previous qualitative work that has done. And so I think for mental health, there's been sort of the opposite, in that there's a lot of importation of mental health instruments from high-income countries into low-income countries. But it's important to begin to understand what is important to mental health from the perspective of women, especially the most vulnerable women in low and middle income countries, to be able to better inform what we measure. We don't want to have quantitative standardized measures that are not really reflective of the experiences of the people or relevant to the experience of people who want to get at.
Thank you so much. We do have a lot to work on already, and it gives us a real push, I think, to move ahead. I want to encourage the audience now to think of some of your observations or questions as we go into the last part of the panel here. You can put them in the chat box and we will have, I think, a few minutes to take them up. What I'm going to do here is I'm going to ask how we what we can do to move forward. And I'm going to first ask Charity to speak again, and then ask Mary about what she's learned from Tanzania in informing the way forward for maternal mental health programs and approaches from her perspective. So Charity first.
Thank you very much, Mary. What can we do to, what have we learned in terms of addressing some of improving experience of care and addressing some of disrespect and abuse? We have learned that with we have implemented both provider and organizational structure interventions that can address these factors. One of them is geared towards reducing emotional stress for providers and mothers who are in labor, either postnatally or with sick children. The first one is training providers on the steps to identify the stresses they may be having, and what do they have stress, what is stressing them, and how can they reduce it both for themselves and the mothers and the patients that they are serving. We have adapted a value clarification and attitude transformation toolkit from IPAS that we did in our RNC Heshima work in Kenya. And later we have used reduced distress and emotional support partnership DEB guide that we have adapted from the Western world, that we are using with mothers with postnatal mothers with sick children that are hospitalized. And this tool helps the mothers to identify when they are stressed, and also to know what to do when they are stressed, and also either to connect with families and also be away from whatever is stressing them. Likewise, for the providers, what can they do? Are they aware that they're having stress? And how can they disconnect from what is stressing them? And how can they be supported by the environment that they're working in? In this, we have the provider debriefing sessions that are in-house, conducted either by a counselor who is in the station or an external counselor. The external counselor seems to work very well. And we are also now implementing follow-up sessions where we connect people, providers with big problems that cannot be solved with 1 or 2 sessions to institutions where they can be followed up later depending on their needs. We're also engaging the ward managers at the facility and health system level to support the providers through structure changes that can enhance a positive working environment, such as a teamwork, space, and that can also ease navigability of parents with sick children in the facilities or mothers in maternity. Also encouraging that providers are trained and recognized, and also having avenues where we discuss how managers can involve providers in decision-making, among others. But last but not least is improving communication between providers and mothers, where we developed a communication tool that helps the providers know what to tell the mothers about certain things when the babies are sick, and also helps the mother in knowing what questions can be asked and how can they approach the providers. So this tool empowers the parents with the sick child to know what questions can they, for example, ask about feeding their child. What questions can they ask during the ward round, and so on. All the procedures that a sick child require, we have given simple tools in a way that, in a language that is easily understood by the mothers, and in a way that they can reach out to providers and seek to be heard, so that they can also get involved in care. They can also get involved in decision making of their young sick children. Thank you.
Thanks so much, Charity. You have so much specific, helpful advice here. I want to turn to Mary now. She's got a lot of experience in Tanzania and what has happened in bringing the issue of respectful maternity care forward, that I hope will inform maternal mental health. Mary?
Thank you very much, Munch. It's an honor to be part of this panel. So very quickly to touch on some of the points where I have been fortunate to be part of this journey, as you have said. One is really looking at the evidence. We know that disrespect and abuse or mistreatment of women during childbirth was widely known, but it was really anecdotal. And the very first gathering of this evidence through the landscape analysis by Bowser and Hill helped us to, it emphasizes the importance of research. Through that, we were able to name and frame this issue of disrespect and abuse. But further evidence was generated for us to be able to understand the extent of this problem and truly what are the causes that made women to be mistreated during childbirth. And so a few years back, before then, we didn't really know how to talk about mistreatment during childbirth. We didn't know how to measure it, but until more recently. And therefore, we understood the problem. We named it and framed it. But what would have been the opportunities of finding a solution? And therefore, that gave us an opportunity for creating learning collaborations, for instance, like those that are on implementation science or focusing on them, where we have looked at how to best create platforms or opportunities where evidence from users, for instance, from the Ministry of that sets policies and guidelines, from implementers who provide and support service implementation in the various levels within our setup, as well as to see how best they can engage with evidence creators. And therefore, it meant really bringing together and identifying who are those, do we have any challenges? Yes, and who are those stakeholders, who are the other stakeholders that we really need to bring on the table, where we can ensure that there is that evidence can be able to advocate for, and therefore it brought up to this movement. My colleagues have spoken about already on at the global level with the movement. Heidi touched on this, but also at the regional level. Through these learning collaborations, we've had a series of meetings, stakeholder consultations that, for instance, like here in the region, the East African EXA Community Health was able to bring a series of meetings. To highlight one of those, we had one where the EXA's Ministerial Forum that brings together ministers from 9 countries within East and Central Africa. And one of the main topics that time was on how to advance, promote more respectful and dignified care. Our minister was the chair, and therefore evidence, from that evidence to stakeholder engagement within the country and now to the level at a regional level really steered up the discussions. And out of that ministers forum, there were resolutions that were made that each country vowed to go and work on implementing them. So just to back up a little bit on the story for Tanzania, one thing that I can say has been a success to where we are thus far, where we're hoping to continue advancing in this movement, is that despite the series of consultations through these learning opportunities and collaborations, there were hurdles, there were challenges. I can't say that the road has been smooth. We are hoping that things now have shaped up just this year we had an opportunity, I can say it's among the most highlights of this movement to advocate, to bring the issues to really the nurse managers, districts, to really look at how best can they, within their settings, try and see how to best continue with efforts to advance provision of more respectful and dignified care. This meeting was a meeting that was, the advocacy was brought about and the highlights by our current Minister of Health. And therefore that has been really a success story that I can say. So we are hoping that moving forward, despite the challenges that we had with delays, it was the perseverance and the persistence of the different stakeholders and some champions from our government that had provided the steering of the effort to ensure that we did not really drop the ball. And every time we went on, despite challenges, changes of the political space and everything, but support of partners, I just want to highlight and acknowledge our colleagues and partners, the HEAD project, URC, funded by USAID, truly has been instrumental, at least for us here in Tanzania, to ensuring that these discussions and consultations have continued. And therefore, when we look at the next phase and the next chapter, where we have gone through all the entire story, we have a national guideline now for promoting respectful and more compassionate care. We're hoping that measurements can really be included in advancing this process, where we can be able to measure ourselves within our national systems and see how far we are, if we're making any improvement, and pause and reflect each time and then, and see that we are hoping to be able to continue moving towards a positive trajectory. Thank you very much.
Thank you so much, Mary, for those very thoughtful comments and the very, very interesting story that is emerging from Tanzania as it tackles these issues. I do see that our idea that we would have a lot of time for questions and response it was perhaps a little ambitious. I want to just note something from the comments here without asking for response, but to bring it up. That one of our participants says mental health issues need to be part of essential care, beginning from primary health care facilities, where ANC and other services are provided. Certainly, I would say in the sphere of respectful maternity care, we are seeing many partners branch out beyond labor and delivery, and feel that that is a new frontier for us and really intersects a lot with what is needed in maternal mental health care. The issues related to barriers, some of them have really been addressed, and I expect there will be more. I wanted to say a few words in closing. To reinforce some things maybe that have been said and some new. It was brought up that this might be a luxury, and that is maternal mental health care, and that it's perhaps optional, and that we really should be focusing on obstetric crises like hemorrhage and eclampsia that are closer to time of labor and delivery and perhaps more visibly killing women, although deep depression and suicide certainly kills women. But getting beyond this business of it being a luxury, I think needs to gather stories and data. And it will be crucial to convince the skeptics. Second, I learned something really important from WHO experts and GBV. And they said something that really surprised me. They said, well, you know, you can start with advocacy before you have the evidence. And what they meant was big trials and large databases. They certainly had evidence from women who were experiencing GBV, and that effective advocacy can attract resources to then improve the evidence and keep this all going. And I think they have shown an amazing ability to do that. The third, I want to reinforce what Charity said about the importance of caring for the carers. Fourth, that people zone out with statistics. So it's good to start with stories. We need to make this human examples and bring together the science with the humanity. And finally, I would say which has helped in RMC, is to demonstrate what can be done in treating all women with respect. We could apply that to addressing common perinatal health disorders. Women will tell their stories while the research provides a growing body of evidence about what works in different environments that will encourage policymakers and healthcare providers and society at large to tackle these problems with skill, compassion, and respect. I want to thank all the panelists for a rich presentation of some of the issues involved in bridging and finding convergence between maternal mental health and RMC. Thank you all so much.
Thank you, thank you, thank you all. What a remarkable panel. I know our final speaker today is going to sum up that session and others, so I will turn it right over to her. But before doing so, from the bottom of my heart, I want to thank you all for allowing me to be your day 2 facilitator. It has been an honor and privilege. I wish to recognize our final speaker, Kenneth Hill. He is a family physician with over 20 years of health systems, services delivery, and quality improvement experience in low, middle, and high income settings. In her role as senior quality advisor for US Momentum Country and Leadership Program, she participated in many global and country initiatives, working closely with colleagues, Ministry of Health, and other country counterparts to support systems-wide improvement of maternal, neonatal, child, and nutrition services. Over to you, Catherine.
Thank you so much, Linus, for that kind introduction, and many thanks for the honor of providing today's closing remarks. As we close the program for day 2, we hope you feel energized and inspired by the practical examples of successful collaboration between the RMN CAH and mental health communities, and the many ways in which we can together continue to strive to achieve evidence-based, gender transformative, person-centered, maternal mental health care for every woman in need. We hope today sparked even more ideas and understanding for how perinatal mental health programming can be integrated into primary health care and incorporated across the continuum of care, including as part of maternal health, newborn health, nutrition, and primary health care platforms for women and families. Today, we heard from colleagues in Pakistan, Zimbabwe, Liberia, and other countries about effective efforts to introduce policies and practices that integrate maternal mental health in services into the health system. For example, we heard from Mr. Lenos about a cadre of mental health workers, family mental health therapists being supported in Malawi. We heard from Dr. Zafar Mirza in Pakistan about the importance of elevating maternal mental health at the highest political level. We also heard about efforts to strengthen the health workforce to be able to deliver and support skilled mental health and psychosocial support in facility-based services to meet women where they are with trained healthcare workers who can effectively identify and address mental health needs in addition to physical health needs. We learned that there is a shortage of mental health care providers, especially in low and middle income countries, and that task sharing and capacity building are important approaches, among others, to address these challenges. We learned about materials to support mental health capacity building for health workers, including the WHO mental health gap training materials, which are links to these are provided in the chats for the respective sessions. We learned from Dr. Oladeji about efforts to make mental health services available at the primary healthcare level in Nigeria, including building capacity of primary health providers to provide simple evidence-based maternal health interventions at the primary level where women most need access to this care. We learned about efforts in Bangladesh and Liberia to build health worker mental health capacity and to link this to policy and advocacy efforts. On a personal note, this topic resonates very deeply with me. I will forever be grateful for the exceptional training and mentoring I received from a mental health provider during my training as a primary care physician. Recognizing that gender inequality is an important risk factor for poor maternal mental health in women, we discussed today what gender transformative programming means, what it looks like, and why male engagement in gender transformative programming is essential for addressing common perinatal mental health disorders. It was recognized that programming must fit into the sociocultural context of the communities where people work. As our colleague Jane Fisher stated, we need to accept that this is a complex problem with multiple determinants. Therefore, single focus programs will not work. We also spoke of the need for a multi-sectoral approach that leverages the unique role of community and faith-based actors and organizations. We learned about the importance of maternal and caregiver mental health for newborn and pediatric health and development. Dr. Bernadette Dalmans from WHO highlighted that maternal mental health has been a component of the WHO MMH Gap Action Plan for many years, but that it is only more recently that caregiver mental health has been explicitly incorporated into child health global guidance. On this note, Dr. Mark Tomlinson and Dr. Bernadette Dalmans reminded us that maternal mental health is one of the petals of nurturing care for newborns and children. Dr. Mark Tomlinson highlighted that mental health and mental disorders exist along a continuum rather than an either or, and that universal and targeted approaches need to be responsive to this dynamic continuum. We heard from speakers about programs in India, Rwanda, and Ethiopia to address maternal mental health as part of small, sick, newborn, and pediatric care programs. And we revisited key themes from yesterday. We dug deeper into approaches for maternal mental health care in fragile and crisis-affected settings and talked about strategies to mitigate the impact of traumatic perinatal experiences on maternal and child health. This session included examples of how NGOs are integrating maternal health, mental health, psychosocial support, and gender-based violence services in humanitarian settings, and highlighted the fact that maternal mental health and well-being is not a luxury, but a basic right that can and should be considered an essential component of every multi-sector humanitarian response. We talked about strategies to mitigate the impact of traumatic perinatal experiences. We heard important lessons learned from experts in the respectful maternity care movement that can help us as we move forward to develop a global action plan to catalyze action for maternal mental health. And we also considered the intersections between maternal mental health and respectful maternity care. We learned about the importance of supporting providers, including supporting providers' mental health if we want to achieve respectful maternity care. We learned about RMC and person-centered care measurement efforts, including validation of tools that address what matters most to women for their experience of care and that are informed by qualitative formative research that is local. Today was another day in which we shared our respective knowledge and learning to date and engaged in an open and frank dialogue about the challenges that remain ahead. But we are invigorated knowing that now is the time to challenge the status quo, demand change, and maintain and accelerate this movement for maternal mental health. We were inspired by the many speakers and stakeholders who are actively engaged in this area and who we can continue to learn from and be inspired from. We encourage you to join us again tomorrow to continue these conversations and co-learning and to continue getting to know each other. If you have not done so already, please do visit our discussion boards, which are accessible via the Consultation platform. You will see a tab at the top of the platform titled Discussion Boards, where colleagues have been posing comments and questions to one another and engaging in lively dialogue. Last but not least, immediately following this session, we invite you to join us for another social networking session where you will be able to network with fellow participants and where we will have a separate dedicated room on the topic of measurement, a theme I know many of us have struggled with for many years and hold dear. Please utilize the link on the agenda on the virtual TechCon platform to join these informal sessions. Additional social and networking sessions will be held again tomorrow, day 3, before and after our official program. Once again, many thank you for joining us today, for all of your invaluable experience, insights, and expertise. And thank you for allowing me to share these closing remarks on day 2. Bye-bye.